Good morning and welcome to this, the 106th episode of the Royal Society of Medicine's COVID-19 series. My name is Professor Henrietta Bowden-Jones. I am the incoming Vice President here at the RSM, and it is an absolute pleasure to be joined by Professor Paul Harrison, Professor of Psychiatry at the University of Oxford, who will be speaking to us about his latest research on neurological and psychiatric disorders post-COVID, and he'll be talking to us about the 2-year follow-up. Please remember this is a very interactive hour, and we are really looking forward to having your questions. Start putting them in the chat and I will make sure I prioritize them by order in which they come in, and we'll spend a lot of time asking these questions. Paul, welcome. It's a real pleasure to be with you again, and please go ahead, and I think we could start our presentation in order for us to have lots of time for questions. Welcome to the RSM.
Thank you very much, Henrietta. It's nice to be back. The pandemic seems to be going on a long time, but we're hoping to share some new data with you, as well as kind of put that into the context of some of the work we and others have done in the past. So if I can manage to share my screen with everybody. Okay, right. So I say good afternoon, good morning, everybody. So I've been involved in a series of studies that have used electronic health records to try and look at the neurological and psychiatric consequences of being infected with SARS-CoV-2. And so the main, I'm going to talk for about 20 minutes. I want to leave plenty of time for discussion on kind of any aspect I'm able to answer about. Just before I get on to the main paper, and this is the most recent study that came out in August in this month's Lancet Psychiatry, where we brought the studies up to the 2-year window of updates. So I'm going to major on the data that we presented in this study, but just again to set the scene, I've got 2 or 3 contextual slides to set the background and how we got to do that study. And before I get on to that, the most important slide is to thank all the people who've done the work. And that's particularly Max Take, who's an academic clinical fellow in our department and has been absolutely outstanding in leading this work to the very highest quality and at real speed, because obviously in a pandemic, there's perhaps a particular pressure to try and get data analysed and published as soon as possible. And we also had the help of a number of senior colleagues, and more recently some of the graduate medical students and other junior members of staff here who've helped us in get the work done. And it's been funded by our Biomedical Research Centre and more recently by MQ and the Wolfson Foundation. Okay, so I just want to introduce the network, the electronic health records we've used for all our studies, because it really is a common template for all the individual studies we've done thereafter. And we've used there are now several large electronic health records networks, mostly based in the US, and we've used one that's called Trinetics Analytics. And this is a health records network with about 90 million patients in it. And those healthcare organisations that the patients are looked after in are a mixture of hospitals, primary care and specialist facilities, and include both insured and uninsured patients. And so our data are a little bit different to some American data you may have seen where they're using insurance claims databases. So our data should be a little bit more representative of the whole American population, although certainly I'm sure there's some degree of bias towards the more insured proportion of society. One of the big attractions of this network is you can access it essentially in real time. So there are data being almost continuously updated from the healthcare organisations that are participating. And so one gets a really very, almost unbeatably contemporaneous upload of the data. So we have, for example, generally had data that are within 2 or 3 weeks of our analyses, and that's then usually within 2 or 3 months of publication. So we've tried to be as up to date as we can be. And through this web interface, you can get access to all the aspects of medical records you'd expect, particularly diagnostic codes. And although it's a US network, they use ICD-10 codes. And so our studies have captured the main psychiatric and neurological codes in that category. We've also, of course, captured all the relevant demographics, medications, and other medical history and investigation items that are available. And what we've done in each study is both measure the incidence of particular diagnoses in different periods after COVID infection, but we've also set up comparator cohorts in order to compare the incidence and therefore work out the hazard ratios associated with COVID-19 versus another health event. And one of the other nice things about this network is that you can do what's called propensity score matching, which essentially means for every patient with COVID, we can identify and match very closely patients with whatever other conditions we're interested in, and we can match them for all the known or suspected covariates and confounders, ranging from age, BMI, race, diabetes, and so on, to really try and be able to identify the factors that then turn out to be different between COVID infection and another infection or health event, rather than simply telling us about the fact that people who get COVID are rather different from the population in general. So our primary comparisons I'm going to show you today are where we've compared COVID-19 infection with any other respiratory infection. So that includes influenza, but it includes the whole range of other infections too. And I'll say a little bit about at the end about the implications of the choice of the comparator cohort that you pick when you're trying to work at hazard ratios. In our early studies, though, we did also use other comparator cohorts, and I'll show you briefly that that really doesn't have actually very much of an effect on the conclusions you come to. The other thing I'd highlight about our comparisons is that these are contemporaneous. In other words, we're taking people who are ill with COVID or whatever other health condition we're interested in at the same time during the pandemic. These are not historical controls, which again, some other studies have done. And we took that approach really to try and control for the effects of all of us living through the pandemic that might have on our mental and brain health. So we've used time-matched control approaches to our COVID cohort. And then finally, and I'll mention some of these today, but not others, we've done lots of sensitivity analyses. So particularly, as you'd expect, we've looked at the effects of the severity of the COVID-19 infection, as well as other ways to try and get at potential confounders to try and help us identify or interpret as much as one can do in studies of this kind, what is really to do with COVID as opposed to other potential explanations. So we've published a number of studies, and before the 2-year study I'm going to focus on. So let me just briefly summarize what we've done in those papers, again, to give you the context for the latest study. These are perhaps our big 3 studies we published previously. And the first one, which at the time seemed a large study with 62,000 cases of COVID, what we did in that study was provide some of the first evidence, first of all, that having COVID infection was associated with a greater risk of common psychiatric disorders in the subsequent 3 months. And we particularly focused on mood and anxiety disorders just because the numbers there gave us greater power. And as I say, we found that the occurrence of COVID was associated with a greater incidence of those disorders in the following 3 months compared to patients with influenza or compared to another number of other health events, including gallstones and some other medical conditions. Now, in that study, we measured both first diagnoses after COVID-19, but also recurrent diagnoses. And the results were very similar. We found an increased incidence of both. But in our subsequent studies, we've really focused almost entirely on the instance of first diagnoses. So people who had not had the diagnosis in question made at any stage before COVID-19. And there are pros and cons for doing that. The reason we did it is because recoding of the same diagnosis in medical records isn't by any means a perfect science. So we've gone for a rather cleaner approach, but it does mean that in the later studies I'm going to show you, we don't know exactly what has happened to people who previously had a psychiatric diagnosis, to what extent they have had recurrences due to their COVID-19, although our first paper would suggest that would have happened. The other thing we did in the first paper, which we haven't done subsequently, was to explore the reciprocal question and show that people who already had a psychiatric diagnosis before COVID were at greater risk of then getting COVID, having it diagnosed, than were otherwise matched people without a psychiatric history. And that association was true even having matched for the physical health comorbidities that we know put people at risk of getting COVID-19. And that finding that psychiatric diagnoses themselves are associated with a greater risk of being diagnosed with COVID-19 is a finding that's been now made in several studies, indeed with greater risk effect sizes than we reported in that study. But it's an aspect of the COVID pandemic that we haven't subsequently explored further, but I think it's an important one. Again, people may want to discuss the findings and interpretation. In the second paper, where we moved to 6 months outcomes, and we also added the common neurological disorders as well as the psychiatric ones. And the gist of that paper was, again, that the majority of neurological and psychiatric diagnoses were being made more commonly in the 6 months after COVID-19 than after other infections, other respiratory infections. Because we had a larger sample and a stronger follow-up, things that had only been positive as a trend in the first study were now significant. So, for example, we found a greater incidence of psychotic disorders and of some neurological conditions, including dementia and stroke. So those findings really strengthened the findings, but didn't tell us, of course, what happened beyond 6 months. Just to complete the picture, we did a very similar study in a very similar population where we tried to look at long COVID. Now, long COVID, of course, doesn't have a formal diagnosis or definition. So we captured 9 symptoms, 9 conditions that seem to be part of most people's definition of long COVID, including various kinds of pain, fatigue, breathlessness, and a particular relevance to us today, the concept of brain fog. I'll come back to that in a moment. And the essence of this third paper was that long COVID features were all more common after COVID. And in this case, we compared them primarily with influenza. So long COVID features were commoner than after influenza, but they certainly happen not uncommonly after flu as well. But we also found that after COVID, you're more likely to have more than one long COVID symptom. So rather than just being isolated, long COVID symptoms are more likely to co-occur and indeed to evolve over time during the 6-month period after COVID than after influenza. So those are the 3 main papers that set the scene for our 2-month follow-up, which I'll come on to in a second. But just to complete the story, and again, these may be things that people want to pick up on later, we've looked at some other aspects of the COVID-19 pandemic. So, for example, we've published on the risks of cerebral venous thrombosis after COVID compared to vaccines, and that was something that's quite controversial and topical about a year ago. We've looked at patients who are unlucky enough to catch COVID despite having had vaccinations. We've looked at the relative psychiatric and neurological sequelae in those people. We've done some work on the effects of being on lithium on your risk of getting COVID-19. And we've done a study showing that being on phenytoin at the time of COVID-19 infection affects your risks of subsequent cognitive impairment. And then finally, a bit differently, we've looked at the incidence and severity of eating disorders in the general population during the pandemic, not associated with particularly having had the infection yourself. So those 5 papers I'm not going to talk about further today, but I say I'll come back to them if that would be of interest. So let me now move to this latest paper where we looked at 2-year follow-ups. And it follows the same sorts of principles and approaches that I showed you in the earlier slide, using this health records network to try and identify the incidence and risks of common psychiatric and neurological conditions, as well as brain fog, in up to 2 years following COVID infection. Again, we've focused on the first recorded diagnosis. In contrast to our previous studies, though, we've now included children of all ages. So I'll show you some age group specific findings for children aged under 18. And we've also included death as an outcome in those getting a neuropsychiatric diagnosis, because of course, as time progresses, patients die as well as develop psychiatric outcomes. And I'll show you some data on that proportion of patients as well. And we've used this study to answer really three different questions. The first is, how do the risks for these various conditions change with time after COVID-19? Hopefully there's no reason to think those risks will continue unabated forever, but we've used time-varying hazard ratios to estimate how the excess risks there might be of a given psychiatric or neurological condition are changing over the 2-year period after COVID infection. And I'll show you some of those time-varying hazard ratios. And we've used them to calculate 2 metrics. One is we've called the risk horizon, which is the time in weeks or months after infection when your risks, the excess risks you had of developing a condition after COVID, have gone back to baseline. And baseline in this group, again, means the same risk you would have had if you'd had another kind of respiratory infection. We then also computed the time to equal incidence. In other words, is there a time in the 2 years after infection when actually the total number of cases is the same in the group recovering from COVID than the group recovering from another respiratory infection? As I mentioned, we've looked at children separately, so we can look at whether the profile of risks is similar in children and indeed in older adults as in adults. And then lastly, we've looked at whether the psychiatric and neurological risk profile is different after the emergence of the common variants of COVID-19. So let me just talk you through those data Again, I'm going to go fairly quickly so I can come back and fill in more of the details if people want me to, but I do want to leave time for questions. So I'm going to start with the 6-month data, and these data are sort of similar to what we did in our previous paper, although the absolute numbers are rather different because this time we are including children. So I'm going to first of all show you the overall hazard ratios for 6 months for each outcome in the whole population. Oh, I'm sorry, before I do that, I was going to tell you a word about brain fog. So because brain fog doesn't have a formal ICD definition yet, these are the codes that were used in ICD-10 to try and capture what we think most people mean by brain fog. So it's a mixture of all the various kinds of dementia, mild cognitive impairment, encephalopathy, and other markers that might be to do with delirium and stupor and other symptoms of that kind. So if we look at the diagnostic categories, here you can see the 6-month hazard ratio for patients recovering from COVID compared to other respiratory infections in about 1.2 million patients. And you can see that for the majority of these conditions, there is a greater risk of getting them after COVID than there was after other respiratory infections. The overall risk at the bottom of getting any of these diagnoses is 1.13, approximating to about a 13% greater chance of getting one of these diagnoses. Although that bottom figure is, of course, very influenced by the frequency, the commonness of some of the diagnoses, of which anxiety disorder and mood disorder are by far the most common, as I'll show you later. But with these findings in this larger sample are really replicating the observations that COVID-19 is associated with a transient, at least, greater risk of these conditions over the next 6 months. If we then break these data down into these 3 age cohorts we looked at, that's children, adults, and older adults, I hope this presents okay. You can see the categories down the left, and then in green are the hazard ratios for children, orange for adults, and red for older adults. And I'm just going to highlight in a couple of versions of this slide some interesting findings that are to do with the age differences in these risks. So first of all, if we take the 2 common psychiatric disorders, that's anxiety and mood disorder, which is almost entirely unipolar depression, you can see that children, in fact, are not at greater risk of being diagnosed with these conditions after COVID at any stage, even over the 6-month period we looked at, whereas adults and older adults, consistent with our findings and others earlier, are at greater risk of these conditions. So at least for these common psychiatric presentations, it appears to be reassuring that children are not being diagnosed with them more commonly than they are after other infections. In contrast, cognitive deficits, that's brain fog, epilepsy or seizures, and psychotic disorders are commoner in children as they are in the other age groups looked at. So there's something rather different about these kinds of conditions that children are as vulnerable to as adults. The absolute numbers, of course, are lower in children, as I'll show you later, but the hazard, the relative risk, is increased in children as it is in older people. I think that distinction, which I'll flesh out again a bit later, may give us some potential clues as to some of the different mechanisms underlying the associations of different conditions with COVID-19 infection. Okay, so having shown you a little bit about the risks over the first 6-month period, one of the main things about this paper was the trajectory of risk and how that changes beyond the 6-month period. And so I'm going to show you some examples of the Kaplan-Meier curves and the time-varying hazard ratios to illustrate just how different some of these trajectories are from one condition to another. Let me start now with the 2 common psychiatric conditions, where actually the greater risk after COVID turns out to be very transient. So on the left, in each panel, in pink and in blue, is the overall Kaplan-Meier curves for the full 2-year period. And at this magnification, you can only just see that in the short term, there is a greater risk of mood disorder and anxiety disorder. But those curves both come together and, if anything, then cross over in the second half of this period. And that's reflected in blue on the right in the time-varying hazard ratios, where in the top panel for mood disorder, for example, you can see that the hazard ratio, the risk horizon, as we've called it, the time at which the risk after COVID is now equal to the risk after other respiratory infections, has returned to 1 within 43 days, so only 5 or 6 weeks after the diagnosis of COVID infection. And if one then follows that time onwards, because the hazard ratio then goes below 1 for mood disorder, by 457 days, you're no longer at greater risk of a mood disorder after COVID than you were after any other respiratory infection. So that perspective, I think, gives a very different view on the relationship between mood disorder and COVID than one looks only at the shorter time periods. And a very similar story is seen for anxiety disorder. Again, the risks are transient, and they are then sort of compensated for by a reduction in risk in the longer time periods after recovery from COVID compared to other infections. So I think that's quite good news, and those findings certainly surprised us, and they contrast with some of the other conditions where the risks appear to be continuing. And I'll show you 3 examples of that: psychotic disorder, dementia, and cognitive deficits of brain fog. And you can see for all 3 of these, the Kaplan-Meier curves remain separated throughout the 2-year period. And on the right, the time-varying hazard ratios remain above 1 throughout this period. In other words, the greater risk of being diagnosed with these conditions remains present 2 years after COVID infection, as great, or certainly in most cases, as it did within a few weeks or months of COVID infection. So these risks are not going away. I emphasize this is not about course of the illness or continuation. These are about new diagnoses. So people are still being diagnosed with psychotic disorder, dementia, or cognitive deficit more commonly 2 years after COVID infection. We, of course, don't know when their symptoms began. These may well be delayed presentations or diagnostic presentations rather than delayed onset of symptoms. But at least this would suggest that as far as the health system is concerned, these new diagnoses are still coming forward at these relatively prolonged time intervals. All right, so those are the 2 main sorts of trajectory of risk we found. Let me now just end with the cumulative incidences of these conditions at the end of 2 years, as well as the proportion of patients who had died. Now, for the slides I'm going to show you now are only for the people who have a 2-year follow-up period. So, of course, that's a much smaller population than the ones we've been reporting on so far, where we were capturing in a Kaplan-Meier way patients who are being censored as they go through time. So I'm going to show you now the data for the patients who had lasted who have a 2-year data. And for this, for the ease of visual presentation, I'm going to divide them into the common, the moderately common, and the rare outcomes. And again, I'm doing it for the 3 different age groups. So this is the 2-year incidences of the common disorders that were measured in this study. And the light bars in pink for COVID and in blue for other infections are the proportion of people getting one of those diagnoses in that 2-year period. And the darker shaded pink and blue are the proportion of those patients who subsequently died within 2 years. So we look on the left, reassuringly, the absolute instances are lower. Of course, there's virtually no mortality in the children, as we would hope and expect. And overall, in the children, if anything, anxiety disorders were less common after COVID than they were after other respiratory infections, and the other conditions don't really show a significant difference. In adults and in older adults, the main findings are to do with cognitive deficits, where both groups are at greater risk of getting one of those diagnoses, the brain fog, if you like, than patients after respiratory infections. And a non-trivial proportion, indeed the majority of patients of older adulthood, are then dying having received one of those diagnoses. I suspect reflecting the frailty and age of that group, because the proportion who have died is the same after COVID as it is after other infections. So I don't think the mortality data are telling us particularly about COVID, they're just telling us about the physical frailty of the people getting those diagnoses in the first place. If we turn to the moderately common disorders, perhaps the finding to pull out here is the vulnerability of children to onset of epilepsy or seizures, which seems particularly pronounced. And then in the older adults at the bottom, the incidence of dementia, as one might expect, is considerably higher than in the younger age groups, and is significantly higher after COVID than after other infections. And that's a finding that's now been reported in several different cohorts, but also highlighting the proportion of those patients who are subsequently dying during the 2-year period. And then finally, in terms of the incidences, the rare disorders, including the psychotic disorders that I've also highlighted. There's some story of muscle disease I'm not going to go into today. And perhaps then at the bottom are 2 findings which haven't really borne out concerns people have had, and that's Guillain-Barré syndrome and Parkinsonism, where again we have pretty weak evidence, if any, that COVID-19 is associated with a greater risk of those conditions. However, I would emphasize that those numbers are much smaller and the number of patients with long-term follow-up for these conditions is reduced. Okay, so the last highlight I wanted to make from this paper was to do with the issue of viral strain. And to do that, we took time windows when the predominant strain just before and just after it changed. Although I'm sure you can't see the detail in the top panel, what we've done is we've taken cohorts of patients who were diagnosed just before versus just after the onset of alpha, just before versus just after the onset of delta, and most recently just before versus just after the onset of Omicron. And we've matched those patients again for the same confounders that we have for the main studies. So we've really tried to pull out as far as you can what might be to do with the strain, not due to changes in the population, overall health, responses to the pandemic, and so on. And for each of the outcomes, we've now shown you the outcome itself, but also the composite of that outcome and death, because it's possible that the strains might have effects on mortality acutely that are different from the effects they then have on neurological and psychiatric outcomes in those who survive. And indeed, that's what we found. So if one looks at green, alpha really wasn't associated with any major differences in either mortality or neuropsychiatric outcomes compared to the previous variant. Delta was worse than alpha, both in terms of neuropsychiatric outcomes and the composite of those outcomes with death. So Delta was bad news. With Omicron, the picture is perhaps more nuanced. So our findings confirm that mortality is certainly less if you've had Omicron than if you had Delta. But our findings suggest that if you then survive Omicron, your risks of getting the neurological and psychiatric diagnosis are really pretty similar as they were with Delta. So one has a sort of mixed picture about the implications of Omicron. I would highlight, though, that Omicron, because of the recency of the peak, we've only got data there up to about 5 months, and therefore it's possible that Omicron will differentiate itself more from Delta as survival times increase. Okay, so as I mentioned, I've gone through quite a lot of data very quickly. I'm very happy to come back to it. I just wanted to end with a slide just to highlight what I think are some of the main strengths and limitations of this work, some of the points I've made already, and then just summarize where I think we are. So I'm not going to go through the strengths of this work. I think it's really to do with the fact they are electronic health records, they're very recent contemporary data, and they're very large, and the cohorts are very well matched. But I do think it's important to highlight some of the limitations, and those apply mostly to health records research in general, but also to this network in particular. Because these are clinical diagnoses made in the real world, we have no evidence as to how accurate they are or how complete. There may well be some missing data because some patients may get some of their healthcare elsewhere, not in one of the organizations that contributes to this network. Because everyone had to have received a diagnosis of COVID or indeed of the other conditions we compared them with, we're probably sampling a more severe than average group. We know, for example, that many people have COVID without it having been recorded or diagnosed. So there may be a bias in our incidence figures pushing them upwards because we've taken more severely ill patients than the population as a whole. On the other hand, in the comparison cohorts, there's almost certainly going to be some undiagnosed COVID-19 cases because we know lots of people, as I've said, have COVID without it being recorded, especially if they're asymptomatic. So some of our hazard ratios may have been underestimated because some of the disorders in the comparison cohort could in fact have been to do with their undiagnosed COVID-19. Vaccinations becomes an increasing issue for studies of this kind as the proportion of the population vaccinated increases. We have matched for known vaccination status in all the studies I've shown you, particularly the recent one, but we know from the percentage of people who are said to have been vaccinated that that is a considerable underestimate. So unrecorded vaccinations in both groups may contribute to the data, and one can postulate it may have either inflated or deflated some of the figures we've reported. Another consideration is that people who know they've had COVID may present differently to their healthcare providers, or indeed the healthcare providers may interpret their symptoms and make diagnoses more or less readily than following other conditions. So I think we need to be very aware of the really uncontrollable potential influence of health-seeking behaviour and diagnostic behaviour associated with knowing you've had COVID-19 infection. There's a couple of other points I won't go into. Just to emphasize a point at the end, we know nothing about the course or severity of these disorders. We're simply noting diagnoses that were recorded in the patient's medical records. Okay, so to summarize, our latest paper, in conjunction with earlier ones from us and other people, showed there's an increased risk of many psychiatric and neurological disorders in the 2 years after COVID-19 infection. The risk of the common psychiatric disorders rapidly subsides, whereas some other risks for conditions, notable conditions such as dementia, psychosis, and seizures, appears to continue throughout the 2-year period. Children are certainly at less overall risk than our adults, but they are certainly still at greater risk of some disorders. Older adults, as one might expect, have the greatest incidences and the greatest relative risks for many conditions. And at the moment, Omicron is looking similar to Delta in terms of psychiatric risk in survivors. And just to leave you with some of the other work that we're doing, because these kind of health record studies are great for some things, but not so good for other things. So first of all, indeed, you may be wondering, if all our comparisons are to do with other respiratory infections, then how do we really know what COVID is doing compared to the population as a whole? And that's quite a tricky question, but we are now completing analyses where we've matched COVID patients to people presenting for similar degrees of healthcare for any other reason. And although those data aren't complete, the findings perhaps look surprisingly similar to the findings I've shown you comparing COVID to other respiratory infections. You may be aware of a big UK study called FOSP COVID, where several thousand patients who had COVID are being followed up and have now been followed up for well over a year. And we are doing some of the neurological and psychiatric follow-up of that cohort to identify what, if any, are the biomarkers when you're acutely ill that predict who are the people who are going to develop these kinds of consequences. And we have some clues, but again, those data are not completely finished. And then finally, in a subgroup of the FOSP COVID cohort, we're doing much more intensive cognitive and brain imaging analyses to really try and understand, what do we mean by brain fog? What kind of an illness, if it's an illness, is that? And what are the traditional brain signatures that might be associated with the subjective complaints of brain fog? Okay, so I've talked for more than enough. I'm very happy to stop there. I'll stop sharing my screen and I'm happy to take any questions that people might have. Thank you.
Thank you so much, Paul. This was groundbreaking, and we feel really privileged to have listened to you like this today. Many questions in the chat, and I'm going to start with Dr. Addy's question, which is the longest by far in relation to all the others. So bear with me with this one, and then we'll speed through the others. I want to try and include everything. So does COVID-precipitated brain fog involve neuroinflammation via mast cells, leading to inflammation in the hypothalamus? And is there any evidence of this pathogenic process could be clinically mitigated by phytosomal formulations of the natural flavonoids luteolin if mast cells activation syndrome underlines long COVID? Sorry, it's a very long question, but if you've got any comments on this, that would be great. Thank you, Dr. Addy.
Right, okay, so no specific questions, answers, I'm afraid, but certainly for all the neurological and psychiatric consequence of COVID, I think one broadly think there are three potential explanations. At least with some evidence. One is inflammatory, and I think that could be either centrally or peripherally mediated. One is to do with microvascular events, and one might more broadly be considered psychological or psychosocial. Now, I'm not aware of any evidence directly linking mast cells, for example, to these kinds of complications. The evidence to our mind at the moment that is strongest is in fact for some of the microvascular complications, perhaps to do with microthrombi in the cerebral vasculature. And I'm happy to kind of expand on that, the reasons I say that if people wish, but in terms of the answer to Dr. Addy's question, I'm afraid I don't have any direct evidence for or against your particular hypothesis. It's one of a number that I've heard of that I think are in play and deserve consideration.
Thank you very much, Paul. And actually, please do, because Andrew McHutchins' question pretty much relates to this. So if you could talk about multiple thromboembolies affecting vital organs, and are these mechanisms also linked to brain damage, that would be great.
Yes, okay. So I said there are a number of theories and some preclinical and clinical studies that have come out about this. And one of the, I think the nicest studies was in Nature Neuroscience towards the end of last year, where a group of German researchers showed that the spike protein of the virus attacks a cell pathway within the endothelial cells lining the cerebral vasculature and basically causes apoptosis and death of the endothelial cells lining small blood vessels. And we know from elsewhere in medicine, I think, that once your endothelia get damaged, they're very vulnerable to microthrombi. So we thought that was a neat potential mechanism. And that particular paper also noted that there are some drugs being developed to try and inhibit that pathway for use in completely separate conditions, mostly in cancers. But interestingly, there's one currently licensed drug which also happens to block that pathway, and it was phenytoin. So that's why we went back and said, okay, if that hypothesis is true, then one might predict that if you happen to have been on phenytoin when you got your COVID-19, your blood vessels in your brain might have been slightly protected from that pathway, and then you'd have a lower incidence of those complications afterwards. And sure enough, that's what we found. So although we think about phenytoin generally as being nasty for cognition and in lots of other ways, we matched the patients on phenytoin for patients on different other anti-epileptics, and we matched them for every other factor we could think of as well. And phenytoin came out better. So we thought that was a very preliminary, but quite a neat support for the hypothesis that damage to the endothelia caused by the virus, followed by microthrombi, might be one of the mechanisms. And that's one of the possibilities we're following up in the FOSP COVID cohort. And indeed, one of the potential biomarkers we've found that when you're acutely ill predicts cognitive brain fog afterwards is indeed a marker of blood clotting. Now, I won't say any more than that, but we think that's beginning to tell a story about thromboembolism. Doesn't mean inflammation and other factors don't matter as well. Of course it doesn't, but it's just the first empirical clues as to what the mechanisms might be.
It's fascinating. We look forward to having you back on this, and it's a clear illustration of real-time research, real-time hypothesis, and then immediately moving on to the study. Let me ask you Derek Knight's question. It has been reported that long COVID can be associated with atrophy of grey matter. Is there evidence that the grey matter recovers?
Certainly not anywhere aware of any evidence about recovery of grey matter. The question may be mentioning referring to the Nature study that came out of the UK Biobank, which showed areas of grey matter atrophy in people following COVID infection. One of the things we're trying to do in our study is to take that work forward and try and collate or relate those kinds of brain imaging volume findings to patients' cognitive impairments after COVID. And of course, there's then the opportunity to follow those patients up later, rescan them potentially, and indeed test whether their grey matter volumes are or aren't recovering later.
Nikki Shiner wants to know, is it possible to distinguish cognitive impairments that result from long COVID to those that might be functional disorders?
Not to my knowledge, and I think it's a really important question because thinking simplistically about the division between functional neurological disorders and other conditions, it would be very surprising if COVID breaks that rule, and one would imagine that there's going to be patients whose long COVID and their other cognitive symptoms may have different explanations. So at the moment, I think we're still, I'm still completely open. I think it's very important for researchers to be agnostic about the different contributions that different factors might be making in different patients. It's one of the goals of the research that we and others are doing to see if one can identify subgroups that may have different explanations for their ongoing cognitive problems.
Sarah Mason Whitfield says, please comment on the marked cognitive impairment that is affecting so many post-COVID and post-COVID vaccine syndrome patients. The cognitive domains impacted, myself included, pose a significant risk to medical practice, but also risk for pilots, gas engineers, teachers, etc.
Well, yes, I'm not sure I can offer any very great insights into that. I mean, I've seen some patients with these problems, and I totally concur that they happen. Our data hopefully have given some idea as to what proportion of patients are getting those problems significantly enough that they're getting that diagnosis recorded in their medical records. So I think any suggestion that people's complaints of brain fog are somehow just subjective complaints and don't matter, I think we can put that to bed. I think the question becomes much more, can we identify better and understand what the nature of these problems is, their severity, their persistence, and of course, in due course, trying to prevent and reverse them.
Is there any update on fatigue in long COVID? Is its nature any different to fatigue disorder pre-COVID? Any mitochondrial involvement?
Not to my knowledge. We mentioned fatigue in our long COVID study in PLOS Medicine that I showed you at the beginning. I forget the exact percentage, but not surprisingly, we found that fatigue was quite a common symptom, as it was in the comparison group of patients after influenza. Whether the pathophysiological basis of fatigue and other long COVID symptoms is the same after COVID as in ME or other conditions, again, I think is one of these critical questions. I think COVID gives us a chance to investigate these problems in a refreshed, new, and perhaps unprejudiced way. But to my knowledge, there aren't any answers yet as to what, if anything, is unique about post-COVID fatigue.
Just so you know, we have nearly 60 questions. We'll work our way through, but this is just a reflection of how interesting your work and your talk are to the hundreds of people listening to us right now. Let me move on. Do we have any data on neurodiversity and impact on cognition in people with autism?
Sorry, I keep saying I don't know the answer to these questions. I don't know the answer to that one either. We haven't explored, if you like, the impact of COVID on people with specific prior diagnoses. I think that's a really important area. We shied away from it for some, well, partly just because of time and also methodological reasons. But I think other studies are beginning to show that people, as you might expect, with pre-existing mental health conditions of various kinds, are not only more at risk of getting COVID, but then appear to be more at risk of then developing difficulties thereafter. There was a fairly large study in JAMA Psychiatry recently, which has supported that idea, but it's an area I think we really need to investigate further, because we're dealing with populations who are already suffering, already vulnerable, and we need to know whether they are following the rules that I've kind of laid out for people in general, or they have their own characteristics and own needs. I don't think we know that yet.
Philippa wants to know, my son, who is age 26, has a rare chromosomal disorder. Did that therefore put him at a higher risk of severe infection? He spent 5 weeks in hospital in May this year.
Well, I think we know that patients with many pre-existing medical conditions, including, I believe, some chromosomal ones, are at greater risk of COVID. It's not something we've looked at because we've had to take this very much population level approach rather than focusing on particular vulnerable groups. But it sounds quite a plausible explanation. Yes.
I've got a long question from Claudia Elizabeth Stein. I'm going to try and shorten it. It's extremely difficult to estimate incidence of insidious conditions such as psychiatric symptoms, cognitive impairment. As you were working from electronic records, how can you be sure that you have not measured previously existing prevalent impairment rather than incidence? This is critical to a certain causality from COVID.
Yes, very, very important question. I'm sorry if I didn't highlight this enough. All the numbers I've given you, or instances, were for patients who did not have that diagnosis recorded prior to the day they had their COVID infection diagnosed. Now, that of course doesn't mean that they didn't have that condition, were developing it, and coming to medical attention because of COVID may have brought that pre-existing condition to attention. Quite agree. That's one of the reasons we were keen to do the much longer term follow-up. So now, for example, we found that your chance of being diagnosed de novo with dementia are still present more than a year after COVID compared to other infections. I think makes that explanation less likely, at least for the majority of patients in any diagnostic category. But the possibility of a bit of bleed through from before the COVID time is something I don't think one can ever entirely remove. So I agree with you. Yeah.
A. Reed says, is there a proven connection between COVID and memory impairment?
Not in a causal sense, no. I mean, it'd be difficult to know how you do that. All studies like ours can show are statistical associations, which by various kinds of sensitivity analyses and controlling for confounders and so on, you can't explain away as being due to something else. But no, it is still possible that these are associations, not direct causal proof. Yeah. Richard
Simpson's question, do you think we will get a tighter definition and coding of brain fog?
Well, one hopes so. I expect so, although it is very difficult to know quite how that's going to look. Whether, for example, there will be a consensus agreement if somebody decides to come up with a diagnostic code for post-COVID brain fog, would there be enough agreement about what it consists of to come up with diagnostic criteria, and then whether you need to do the usual metrics on reliability, for example. I showed you earlier on the kind of group of pragmatic categories we had used to capture brain fog. I should perhaps highlight that you will have noticed the first of those were so-called R codes within RCD-10. These are not diagnostic codes, these are symptom codes. And the large majority of people who we included in our category of brain fog were getting in that category not because of dementia, but because of one of these R codes. And what that suggests to us is that many patients are presenting with complaints of cognitive difficulties, and doctors are recognizing them, but they're falling short of what it takes to make a diagnosis either of dementia or mild cognitive impairment. And I think further drilling down into what exactly is it that people are presenting with that doctors are noticing and agreeing with that isn't well captured on our current diagnostic codes is something of a priority. Yeah.
Next question for you. Is there a change in emotion, memory, or aggression? Is there evidence that COVID can impact on the limbic system?
Well, the UK Biobank's brain imaging study I mentioned earlier that published in Nature, and it had scans from people before and after their COVID infection, found these subtle but demonstrable brain volume reductions, and they were to a large extent concentrated in the limbic regions of the brain. So I think that is plausible. Again, it's something that needs further research. What the mechanism of that is, how can the virus be more selective to some brain regions than others, for example? I think those are good questions, but I think there is a bit of evidence from imaging that may to some extent be the case, yes.
Thank you, Paul. Now, I'm trying to be polite and kind to hundreds of people, and I'm doing so by not allowing too many people to have more than one question. So if you're one of the people who's asked 3 and I've only asked 1, it's only just to give everyone a chance, so you know why, not because your questions weren't valid. Jude Halford wants to know, is there data on suicide?
It's not something we've looked at because, well, partly because it's not particularly well captured in the system. So I think that's a very good question. We haven't explored the causes of the mortality data that we've shown you. I think a couple of other big studies have looked at suicide after COVID infection, but I'm afraid I can't quite remember what the gist of the findings was.
Yeah. Cecil Kolaka wants to know if there's any impact of confounding variables from those vaccinated after COVID or before COVID.
Well, as I mentioned in this study, we matched for known vaccination status across cohorts, but we didn't capture many of them. In our earlier paper, we did very carefully match people who got COVID after vaccination with the other group. And although as you'd expect, we found that the chances were much lower and that you were much less likely to get acutely ill if you got post-vaccination COVID infection. Again, the risks, if you then, your subsequent risks of then developing common psychiatric and neurological conditions wasn't demonstrably different in the vaccinated from the non-vaccinated. So we didn't find evidence really that the vaccinations protected you against the longer term sequelae of COVID if you were unlucky enough to catch it. But I should say that there's a couple of other big studies that have found a degree of protection. So I would be very cautious in our negative conclusion on that point.
Anne Malkin wants to know, does COVID decrease the effectiveness of anti-epileptics in epileptic patients who previously had well-controlled epilepsy?
I don't know of any evidence about that. Because epilepsy and seizures are quite an interesting and somewhat difficult area for the way the diagnoses are done, we've actually got a separate paper in Press where we've looked in detail at epilepsy and seizure diagnosis after COVID. But again, in that study, we didn't explore the kind of pharmacological question about drug responsiveness. It's another hypothesis which would need to be tested.
I'm thinking that as we sometimes do, we might actually send you all the questions, and maybe someone in your team might find questions they might wish to focus on in terms of responding to some of our delegates, if that works well in the, after this hour. Jill Rasmussen says, was there any effect of vaccine type, number, on risks for complications in the various populations types of CNS disorder?
Hello, Jill, if you're the Jill Rasmus I know, welcome. Because it was the US study, we only had the mRNA vaccines, and they were, as I recall, about 3/4 Pfizer vaccines and 1/4 Moderna. We didn't have any of the other vaccines in that population. And I don't I can't recall. I think in the supplemental we might have looked at vaccine type. We didn't, I don't think, find anything. We also subdivided people who'd had one dose versus two. And as I recall, there was a slightly greater protective effect of two vaccines, but the vast majority of people had two. So we were a bit underpowered for the one dose only subgroup.
An anonymous attendee says, I pre-submitted a question on the number of COVID infections and cognitive impairment and their implications for clinicians and consequent patient safety. Yes, over to you, Paul.
So we've only intentionally studied people on their first recorded COVID infection. As I mentioned earlier, recurrent, if someone has it recoded later, there's always a worry it's the same diagnosis being recoded rather than the second infection. So we haven't looked at intentionally whether a second infection makes any difference to what we've looked at. Again, there will be a sub-proportion of patients who will come into that category. I should perhaps have it on my list of limitations or something else that increasingly with time will be another factor that will make these analyses more complicated.
Sally Millership says, is there any information on the effect of prior vaccination on the incidence of neuropsychiatric disorders in those who get COVID?
Well, yes, that's the earlier paper I've mentioned, which I can give chapter and verse to. It was published in I have to remember the chapter and verse for that, but I'm happy to forward the email of that. I'll post it in the chat if I can dig it out while we're still on the call.
Yes, don't worry about doing it now because I'm bombarding you with questions. Okay. And however clever you are, you won't be able to multitask that much. So I think better stick to the questions, and then you can even forward it to me if you want, and I will deal with it. Richard Simon Trumpeter says, you list insomnia as a long-term issue. Do other disordered sleep patterns occur? For example, excessive sleep, or is this just a feature of a post-viral fatigue, chronic fatigue syndrome?
For the insomnia question, we stuck to the two diagnostic categories in ICD-10 for insomnia disorder. There's an F code and a G code. So we very much focused on insomnia as the concern. We haven't, as I recall, explored subtypes of sleep disturbance. And as I've sort of said in response to other questions, whether this is something specific or it's just part of a more general post-viral fatigue, I think it's very difficult to know. In our long COVID paper, it certainly wasn't that everyone who's tired is fatigued and vice versa, but I'm sure there's going to be a big overlap in the patients who have those complaints and diagnoses.
Yeah. Sally Hull's question, do you have any evidence of the relative incidence of these conditions following COVID in different ethnic groups?
Yes, in our in one of our 6-month papers, we did compare in the two groups where we had enough patients. We had white patients and African-American patients, and we explored these outcomes in those two groups, matched groups separately. And as I recall, there was remarkably little difference in any of the outcomes between those two groups. We haven't explored other ethnic populations though.
Margaret Fiona Bassendine wants to know about hepatitis C, its impact on the brain, and whether that might have been an interesting comparison rather than using respiratory viruses.
Yes, and we've discussed a number of other potential comparator infections and other health events. The difficulty, of course, is once you pick a rare infection, and we're only after contemporaneous controls, there just wouldn't be enough new patients presenting with hepatitis C to match our COVID cohort to. You know, we've got over 1 million patients who've had COVID, so you really want to match the comparator group that's as big as that. Whereas I imagine for hepatitis C, it might most be a few thousand cases, and therefore we'd have far less power than we have when we pick common outcomes. But we've also thought about we thought about herpes simplex, for example. There's another other encephalitides, but those suffer from the same difficulty. As I've mentioned in our latest work, we're trying to come up with different kinds of comparator cohorts, because again, it's the triangulation of findings from different comparisons that I think in the end gives you the clearest picture. But I must admit, we didn't look at the numbers of hepatitis C, but I doubt there would have been enough to do a meaningful analysis.
Clive Bowman wants to know if there's any modulatory effect on in relation to which type of vaccine.
As mentioned, not insofar as we're able to look at that, but we've not looked at the AZ or J&J vaccines, for example, so we can't comment on that.
Pippa Dolman's question, excellent presentation. Is there any data, current or coming, on prognosis for neurocognitive impairment which appears to worsen in the months after initial COVID-19 infection?
Well, so the FOSS COVID cohort study I mentioned, where they had a paper in Lancet Respiratory Medicine, I think last year, they were looking at the outcome up to 6 months. And again, things at 6 and 12 months, and things weren't really getting any better if you'd had the problems at 6 months versus 12. But that cohort is now being followed up for longer, and we and others are doing more intensive follow-ups of that group. So one of our really priority questions is what happens to these difficulties in people who have developed them? Are they going to get better, or are they not going to get better? I think it's a critical question. Electronic health records research doesn't really allow you to do that. You've got to do longitudinal studies. And we think FOSS COVID and another big study called COVID CNS in the UK are the kinds of studies we're going to need to do to answer those questions.
Richard wants to know whether you'd like to comment on the implications for psychiatrists and GPs of your findings.
Well, there's going to be no shortage of work, I'm afraid, and probably for neurologists too. So the usual, requests for more resources, both human and otherwise, to deal with these problems. I think it's going to be really difficult. I mean, the mental health needs of the whole population because of the pandemic are bad enough. You then add on people who've had the unfortunate or the misfortune to develop these complications after COVID-19. There need to be resources, even whilst we're working out what are the appropriate and evidence-based interventions that need to be available to help these people, rather than simply help them receive a diagnosis, which is really all that's available at the moment. Yeah.
Leslie Ritchie wants to know, have you looked at incidence of migraine as part of long COVID?
We did look, yes, we looked at headaches, and I think we subdivided migraine. That will be buried in a supplementary table from our PLOS medicine paper. I'm afraid I can't remember the numbers offhand, but yes, you'll find it somewhere.
Charles Bernard Shepherd is asking about cognitive dysfunction being a very common feature of ME, CFS, and the overlap between long COVID and ME. He says, surprised that you're not checking for this in your ICD coding.
Yes, that is a very good question. And I can't now recall whether we did that intentionally or by omission. But because of our continuing interest in obviously fatigue and brain fog and so on, that's a very helpful point, and I will try and remedy that if we haven't already.
We've got time for just one more question. I'm going to try and stick to time because I know people have other things after lunchtime. So Eddie Blair, what differences did you see between infected, vaccinated and post-vaccinated infected groups?
Sorry, could you just repeat that?
Yeah.
Comparison?
What differences did you see between infected, vaccinated and post-vaccinated infected groups? I'm just reading out the questions as it is.
Yeah, sure. Well, I think that's the kind of the same. I think that's the question about the vaccination data paper, which is the one that I can forward you the reference to, Henrietta. We didn't look at that in the most recent study. We just tried to kind of take vaccination out of the picture as far as we could by matching the groups.
Excellent. So then let's finish on one last question. William Tawney, are there CSF protein abnormalities on electrophoresis?
There are, not surprising, the numbers of CSF sample studies I've seen are much smaller than there are for plasma biomarkers, for example. I'm not aware of any particular robust CSF finding, certainly one that's been replicated, but it's not an area I'm completely up to date with. So there may be other people on this call who know better about the current CSF data. It's obviously something that we and a number of people are interested in, because the CSF is clearly a lot closer to what's going on in the brain than any peripheral markers are.
Thank you so much, Paul. If you just stay there for a second, I need to do a couple of housekeeping things. I'd like, first of all, to remind all of you that it's not too late to book onto our clinical masterclass series, Update on Sports Medicine, taking place this evening at the RSM, if you're interested. I'd also like to tell you that on the 14th of November, in person, we have the Women in Medicine Leadership for the Future of the NHS, and please come and join us. And finally, Tackling Inequalities Conference has a new date now, the 11th of January, a whole day conference. It will be a very big day for us, and we look forward to having you all with us. Now, the second issue is, please fill in your feedback forms. This has been a most incredible session, and we'd like to hear from you when you receive the email. Lastly, I'd like to thank Paul for giving up his lunchtime, coming to talk to us about his groundbreaking research, and I very much look forward to further updates in the future. Goodbye, everybody, and thank you to all of you for the wonderful questions. Goodbye.
Thank you.